Our lecture today is about the systemic fungal infection. So this is the objectives of our lecture today, to know about the different common type of the fungal infection and which patient who is reliable for such an infection, and the site of the infection, and even the clinical features and the type of the treatment. Most of the systemic fungal infection is an opportunistic fungal pathogen, and it's mainly happened in the immune compromised host. However, still invasive disease can be occur in immune competent, especially if the person has been exposed to the high dose, or there is a primary fungal pathogen which causes endemic mycosis like blastomycosis, astoplasma, coccidioiditis, and other type of the fungal infection which can be happened in the immune competent person. Systemic fungal infection usually originate either from بالحقيقة this is يعني can be happened or involve the lungs like Aspergillus, Cryptococcus, and the Mucorales after inhalations of the molds, or from the endogenous flora like the yeast with the Candida species as a result, either because of the central line infection or leakage from the gastrointestinal tract, definitely because of the epithelial destructions of the gastrointestinal, which make these infection can cross to the blood. Systemic fungal infection, once it is diagnosed, so it is medical emergency because it carries high mortality rate, and appropriate therapy should not be delayed for this patient. And antifungal treatment is often initiated when the infection is suspected clinically. So it's mean that when the patient you suspect clinically, you should start antifungal treatment sometime before the investigation. So this is what we call empiric type of the treatment, or emptive type of the treatment of these patients. So the first and the commonest type of the candidal infection is the بالحقيقة هي الكانديدال infection. والكانديدا is لما نقول candidiasis, it means that infection with the candida, and the most common type of the candidal albicans, despite we have other type of the candida راح نشوفه بعدين, and it can be localized, it can be involve the skin or mucocutaneous, or can be disseminated, which can involve different organs like the eye, can be over the renal system, cardiac, or it can be like other bacterial infection can cause disseminated intravascular coagulations. And you see this is the pictures which is with the skin involvement of the candida of the skin, and we see that there is a macronodular skin involvement by the non-tender, typically by the non-tender pink red, this macronodules, and there is ophthalmic involvement by what we call the cotton wool oxidate, as we see in this picture. And this is the oral thrush involvement of the oral mucosa. And as we said that the candida is the most common type of the fungal infection, with the 80% of the major systemic infection, fungal infection caused by the candida, and this is mainly been in immune compromised patient. And still the candidal infection is one of the most common hospital acquired infection. And as we say, because as it is an endogenous, so it is as a part of the commensal organism, can be colonize the GIT and the skin. Unlike, as we said, the other systemic mycosis like Aspergillus or Cryptococcus, which originate maybe by inhalations or other routes, but here is endogenous, as we said, from GIT, or when we have an application of the central line, or we have an abdominal surgery, but it is mainly endogenous. As we said, the most infection caused by Candida albicans, despite other non-albicans species are increasingly involved at the time being. And again, this is the oral, extensive oral thrush with the candidal infection, and this is to the left the esophageal involvement of the candida. Again, we have skin involvement, as we see, oral, eye, and hepatosplenic involvement. Other manifestation, as we said, as part of the systemic form of the candidiasis, may be the renal, maybe genitourinary, maybe osteomyelitis, maybe septic arthritis, peritonitis, and meningitis, and valve involvement in the form of the endocarditis. In general, candidiasis can be, or disseminated candidiasis can be divided into the acute and the chronic form. And as we said, the acute form, it's mainly happened in those patients who have a predisposing factor like central venous catheter, or those patients who have recent abdominal surgery or total parenteral nutrition. And they found that 40% of these cases they have ophthalmic involvement, and as we said, they have characteristic retinal involvement in the form of the Wachuten wall oxidate, and this is the life-threatening actually for the vision, and it may lead to the blindness in these patients. Again, skin involvement in the form of the macropapular nodules. And again, this type of the acute form can be happen in those patients we are facing, in those patients with the intensive, commonly in patient with the intensive care and surgical patient. Again, those patients who are a intravenous drug user has been labeled for candida. Systemic candidiasis, this is because of the candidal contamination of the citric acid or lemon juice used to dissolve heroin. The chronic disseminated candidiasis, this is mainly happened in those neutropenic patients. These patients, they have persistent fever, and these patients, they develop abdominal pain, raised liver enzyme, mainly alkaline phosphatase, and they have multiple echogenic masses detected by the ultrasound. And these patients, in addition to the invasion of these organs by the candida, they have what's we called immune reconstitution inflammatory syndrome, which may last for several months despite appropriate therapy. So these patients, they may need for long-term treatment. As we said, non-albicans candida has become increasing more and more with time, and 50% of these and now of the candida is mainly it is non-albicans candida. And as we said, these infection disseminated form, it is mainly hematogenous spread, which can causes multiple, can involve different organ like eye, skin, and it may lead to the micro abscesses in different organ of the body. So the older standard or the gold standard actually for diagnosis of candidemia is positive blood culture, as we said, because as it's hematogenous. So once you find candida in the blood culture positive, so you can say this is 100% these patients they have candidemia. All intravascular catheter, if the patient he have central venous line, so these catheters should be removed in addition with the antifungal therapy. And as we said, this is other type of the candida. In addition to the candida albicans, we have tropicalis, cruziae, lewistani, and parapsilosis, and glabrata. And these different type of the candida become very important to diagnose because they have different type of the resistant and different sensitivity to different fungal infection. Because like cruziae, these patients they have resistance to the fluconazole, but still they have sensitivity to other drug like voriconazole, and even candida glabrata isolate. They have what's called a susceptible dose dependent or resistant to other species than طبعا تكون more resistant than other species to the for antifungal therapy. So we need to determine the type of the candidal infection to determine which antifungal therapy for this patient. Again, this is the skin involvement by the macronodular fungal infection, candidal infection. Again, this is the CT, which show there is a multiple echogenic involvement by the CT, and this is because of the micro abscesses caused by the candidiasis. Which is the patient they are at risk for candida? As you see, there is a long list of the immune suppressed patient, in addition to the central line catheter, in addition to the abdominal surgery, in addition to the intravenous drug abuser. Those patients, they have organ transplant, whether solid or post-marrow transplant, they are liable for infection. Even the use of the broad spectrum antibiotic in these patients can make these patients liable for candida, and we are facing بالحقيقة those patients who are used for a long time. We face these patients, they have تبعون oral thrush بالمouth عندهم هذول patient after using long time of the broad spectrum antibiotic. Again, those patients who they have congenital immune deficiency, like severe combined immune deficiency, and those patients, they have defect in the oxidative burst of the bacterial destruction, like myeloperoxidase defect. These patients make these patients liable for fungal infection. And this is necessary, as we said, this is necessary to diagnose those patients with the systemic type, even with the candidemia, because the mortality still with the candidemia can be reached 30 to 40% in these patients. And as we said, the clinical manifestation of the candidemia, as I said, the presence of the candida in the blood, they can present like full-blown sepsis, and they may present with the DIC and can be involved different organ involvement of the eye, kidney, heart, or valve, or the brain. So how to diagnose invasive candidiasis? Diagnosis is, as we said, positive blood culture, and the culture returned back in a good lab with a good technique after 1 to 2 days. And blood culture technique are relatively insensitive, as only 50% of the positivity in autopsy proving disseminated cases. Again, if we have like skin involvement, we may have tissue biopsy from these, or any focal lesion can be determined. And now we have what we call serology for determined if we have candida, despite this is beta-D-glucan assay. This is not specific for candida, but still, if you have this positive test in the sequential sample, you can maybe helpful for diagnosis of the candida. It's particularly useful those patients who they have deep-seated invasive candida, like intra-abdominal, because sometimes the blood culture, as we said, it is insensitive because it's positive in 50% of these patients. So the main treatment of these patients, as we said, the azole group, we have many groups of the antifungal at the time being, like azole, voriconazole, echinocandins, and at the time being we have liposomal form of the amphotericin available. As we said, fluconazole is a good drug for candida albicans, despite other type of the fungal infection, like as we said, the non-candida like glabrata and cruziae, which is usually universally resistant to the fluconazole. We need other treatment like other azole group like voriconazole. Echinocandin is now good options again for these patients, like caspo, fungin, andulofungin, mycofungin. Amphotericin B again have a good activity against candida. And the therapy is adjusted according to the clinical response, species involved, and even the duration sometime for this patient. But in general, we need to use sometimes we need to continue treatment for this patient at least 14 days. Now we are talking about the aspergillosis. This is the other form of the serious fungal infection with the high mortality rate. And as we said that aspergillosis, we get the aspergillosis from the as from the environment, because the aspergillus is found as a saprophytes living in the soil and the planets, and we get it by the inhalations of the conidia, where this aspergillus go to the respiratory tract and causes disease. So tissue invasion is uncommon and occur most frequently is mainly in the immune suppressive patient. Substantial outbreak of the disease may occur in immune compromised patient, as we said, especially those patients with the hematological malignancy, those with the bone marrow transplant, and those use corticosteroid for a long time. This disorder may be more common than previously thought in patients with the chronic obstructive airway disease. So the patient with the chronic obstructive airway disease, these patients, they are liable for aspergillosis. Invasive aspergillosis is often fatal, with the mortality rate reached about 60%, and this rate higher in those patients who have bone marrow transplant and can be reached 90%. The conventional diagnosis of these infections actually most of the time there is a combined combination of the features in addition to the serology, in addition to the PCR. As we said, it is most commonly involved the pulmonary, so it is rarely to find these aspergillus in the blood, but still the aspergillus can be involved gastrointestinal tract, can be involved the skin or other organ like the brain. So this is the clinical feature, as we said, this is most commonly involved the pulmonary and can be involved what we call it endobronchial as a form of the tracheobronchial, especially those patients who have lung transplant, which causes actually large airway invasions and causes fungal plague and ulceration by the scalp. Chronic necrotizing and chronic cavitary pulmonary aspergillosis in those patients with the pulmonary aspergillosis, disseminated infection which can involve different organ. Sinus is the second site of the involvement in these patients in the form of the rhinosinusitis. CNS, as we said, eye involvement, endocarditis, cutaneous form, and gastrointestinal form. Culture isolation of Aspergillus species from the airway does not necessarily indicate the disease in immune competent patient. So if the sputum contains aspergillus, but this is not necessarily that the patient had aspergillosis. So most certain evidence of the invasive aspergillosis by the culture in combination of the evidence of the tissue invasion by the histopathology. And so this is the gold standard. If we have culture positive in addition to the histopathology, which show the septate hyphae or septate hyphae, yes, we can say this is aspergillosis. Culture from normally sterile site, so if we have like pleural effusion and it's revealed aspergillosis, so you can say this is definitely aspergillosis. In patient, we have risk factor. He is immune compromised, like we said, the patient, he has transplant, he get chemotherapy, he's immune suppressed, and he have radiological feature like the CT, which show halo sign and feature suggestive of an invasive aspergillosis. Culture of Aspergillus species from respiratory secretion or finding typical hyphae on staining of the respiratory secretion, you can say it's high predictive value. So we have, if the sputum, as we said, in immune competent patient sputum, you cannot say this is not necessarily there is aspergillus infection. But if the patient, he have typical radiological manifestation, he had risk factor for aspergillosis and sputum or respiratory secretion by bronchoalveolar lavage or by the sputum examination, and it's revealed the aspergillus, so you can say this is aspergillosis. And this is high resolution CT, which show what's we called halo, which show multiple foci of the ground glass opacities and multiple pulmonary nodular infiltrates, which is mainly the macro nodules in these patients. Again, this is what you called halocyon. If there is holocyon, as you said, this is because hemorrhage, which can happen after 5 days of the presence of this infiltration, which is highly suggestive of the infection of the angio-invasive fungal infection. So it is halocyon, despite it is not characteristic of the aspergillosis, but once you find in the radiologically, in addition to the as we said, presence of the risk factor, in addition to the presence of the positive sputum, I can say this is most certain about the aspergillosis. So aspergillus organism observed in biopsy specimens, several have similar appearance to other filamentous fungal infection like scedosporiums or fusarium in the histopathology. So in the histopathology alone, you cannot discriminate between different type of these filamentous fungal infection. So we need culture to say this is aspergillus or scedosporium or this is fusarium. The treatment of infection caused by these fungi may differ, as it's important to confirm genus and species by the culture. Histopathological examination can usually distinguish aspergillus and other fungi described above from the mucorales. This is other beneficial test because, as we said, as aspergillus is commonly involved the pulmonary, and as this patient, we are facing this patient, they have respiratory distress. It is difficult to have a tissue biopsy from these patients. So most of the time we are depending on the blood test, which is serological test, but which we call the beta by the galactomannan antigen, which is available on the serum. And can be used as adjunctive test for the diagnosis of the aspergillosis. The other test, and as the utility of the serum galactomannan assay has been best established in the setting of the suspected disease in patients with the hematological malignancy. So the clinical criteria, before we proceed to the treatment, the clinical criteria for diagnosis of aspergillus, the presence of one of the following can be on either by the image, as we said, presence of the halocyon, presence of what you called air crescent sign, or presence of cavitary lesion, this is by the CT, or as we said, by the microbiological, by the presence of the moles in the sputum, either sputum or bronchoalveolar lavage fluid or bronchial brush, with the presence of the fungal elements or molds of aspergillus, and indirect tests, as we said, galactomannan, and other tests like beta 1,3 glucan اللي هو طبعا we are mentioned بالcandida, but still هو can be, it is not a specific test for candida or aspergillus, despite it is have high sensitivity. So beta 1,3 glucan detected in the serum can detect, as we said, other type of the fungal infection in addition to the aspergillus. Treatment. So the treatment of this first drug of the choice is voriconazole, and other type of the treatment is amphotericin. Definitely fluconazole is not a good option in this patient. Itraconazole still can be acting in this patient, but still there is a high resistance at the time being. Echinocardins such as caspofungin may be also effective therapy in these patients. What's about the mucormycosis? This is another invasive fungal infection. Again, this is severe uncommon type of the opportunistic systemic mycosis, which is mainly caused by the what's we call the mucorales, and it is mainly caused by the Cladus species or Rhizomucor species or Mucor or Rhizobus species. So the risk factor for these patients, either patient who they have احنا most نشوفها بالبرادات سواء الباطنية أو other wards. Those patients who they have uncontrolled diabetes, or those patients with the diabetic ketoacidosis, these patients particularly liable for the mucormycosis. And those patients treatment with the glucocorticoid, and this is what we are faced بالوقت الحاضر بما يسمى الفطر الأسود اللي هو طبعا اللي هو because now اكو correlation يقولون بين ال COVID-19 infection and the increased risk of the mucormycosis, and this may be related to the use of the steroid in this, excess use of the steroid in these patients, or by other mechanism. Hematological, again, those patients with the hematological malignancy treated by the chemotherapy, those patients who undergo stem cell transplant, solid organ transplant, and those patients who they have iron overload, like those patients with the thalassemia, those patients with the sickle cell anemia or other iron-loaded anemia, these patients, they are liable for a mucormycosis, and even treatment with the iron chelating therapy may predispose these patients to the mucormycosis. Again, other drug like other risk factor like injection, drug use, a burns patient and malnutrition make these patients, they are liable for mucormycosis. So the disease pattern is most commonly we are faces is what we called rhino cerebral and craniofacial form, and still we may have pulmonary, cutaneous and systemic disease, and all these characterized by rapid development of the severe tissue necrosis, and it is always fatal if it is left untreated. So the infection usually presents as those patients with the rhino, what's called the rhino orbital cerebral mucormycosis. These patients usually present with the acute sinusitis and fever, nasal congestion, purulent nasal discharge, headache, and sinus pain. All of these sinus become involved, and it can be spread to the contagious structure such as palate, orbit, and the brain. And this infection progresses rapidly. As we see, there is severe necrotizing tissue which involve the nose and extend up, involved to the cavernous sinuses with the periorbital swelling, redness, and as we said, this is rapidly disseminated to the brain. Pulmonary mucormycosis, despite it is we are faced less than the aspergillus, but still can be happening, it is rapidly progressive infection that occur after inhalation of the spore into the bronchioles and alveoli, and the pneumonia. And as we said, with these patients, they have as an angioinvasive. This leads to the extensive necrosis and infarction. And these patients, they present with the fever, hemoptysis, and can sometimes be massive hemoptysis. Other organ can be gastrointestinal, as we said, cutaneous, renal, and isolated CNS involvement. So diagnosis of the mucormycosis rely actually on identification of the organism by the histopathology with the culture. For histopathology and culture, and unfortunately serology in this patient, we have no serological useful for diagnosis. So culture and histopathology for diagnosis of the mucormycosis. In general, treatment usually we need combined therapy. In addition to the antifungal, which is not enough alone for treatment of this patient, we need surgical debridement, and in addition to treat the underlying cause. So the best drug which acting on the mucor is intravenous amphotericin B, or oral posaconazole can be used in these patients, which can sometimes be used in those patients who are used for amphotericin for a long time, and can be used as step-down therapy for these patients who they are responding to the amphotericin B. And it is rarely used as a salvage therapy for patients who do not respond to or cannot tolerate amphotericin B, because as you know, the amphotericin B had many complications, and sometimes we need to replace this drug, especially if the patient is intolerant or because of adverse effect. Another type of the fungal infection, and this is what's called cryptococcal infection. And the cryptococcal infection, again, this is one of the opportunistic mycosis and can be involved. Actually, we get this infection by the inhalations. And this, as we said, despite we get this type of the fungal infection by the inhalations, but still pulmonary involvement as an isolated organ is rare. But most common organ, it's involved the brain, and these patients is usually immune compromised patients, especially those patients who they have HIV and acquired immunodeficiency syndrome. So cryptococcal meningitis usually is more frequently encountered in these patients. The cause is maybe for the organism, as we said, we get it by the inhalation, but it can be disseminated hematologically, hematogenously, and it can be involved different organ, but mainly it is the CNS, but still can be the brain, skin can be involved by the cryptococcal infection. Most patients with the cryptococcal meningitis, they are immune compromised, and the most common form of the immune suppression, as we said, this is either the patient who have HIV or acquired or AIDS, or they use glucocorticoid for a long time, or those patients who they have solid organ or stem cell transplant, hematopoietic stem cell transplant. Other conditions like hepatic failure and sarcoidosis, these patients still they are liable for cryptococcal infection. So the clinical presentation of these patients is variable. Some patients they have symptoms, indolent course. They are presented, especially those patients with the CNS, they are presented mainly with the headache and other features of the increased intracranial pressure, because as we said, because it is little bit more indolent, so they present with the headache. They may be present with the personality changes. They may be presented with the memory loss, or even sometimes they have disturbed in the vision. The treatment of this patient, before we proceed to the conclusion for this patient, so the main treatment of the patient with the cryptococcal infection is amphotericin combined with the fluoxetine as an induction treatment. This is followed by the consolidation with the fluconazole, and sometimes we continue for this treatment with the fluconazole as long as the patient is immune compromised, like in a patient with the HIV patient. So in conclusion, the cryptococcal meningoencephalitis is often the most frequent encounter manifestation of the cryptococcus. Most patients with the cryptococcal meningitis, they are immune compromised, and as we said, the extrapulmonary is mainly CNS. Symptomatic pulmonary cryptococcus can also occur in apparently immune competent patient. And thank you very much.